Alrighty. Hi, everyone, and welcome. My name is Felicidad, and I'm the Communication and Resolution Program Manager with the Foundation for Healthcare Quality. Thank you all so much for joining today's session, Regulatory Readiness, CRP, and the Patient Safety Structural Measure. To quickly go over some housekeeping, please keep your mics on mute. We will have time for questions at the end of the presentation, which at that point you are welcome to type any questions you have in the chat or to come off mute and ask your question. This webinar is being recorded and the slides will be sent to all registrants once it's available. So that's it for our brief housekeeping. But before we dive into our exciting and full agenda today, I'd like to take just a few moments to share a little bit about the Foundation for Healthcare Quality and the Communication and Resolution Program support services we offer. So, starting off with the Foundation, we are a nonprofit certified patient safety organization based in Seattle. The Foundation is a trusted third-party resource that's available to all participants within the healthcare community. With our designation as a patient safety organization, it grants us federal-level confidentiality protections that allows us to expand the use and participation of all of our programs nationwide. Here in Washington, we have state-level confidentiality protections under Washington's Coordinated Quality Improvement Program, otherwise known as CQIP. So we house a variety of programs focusing on innovative and data-driven concepts such as measuring and enhancing healthcare quality, improving patient safety, and responding to adverse events with transparency and compassion. One of the programs housed within the Foundation is our Communication and Resolution Certification Program, which aims to increase education and awareness of CRPs and foster consistent utilization of the CRP process. This program offers two pathways for free and confidential CRP case reviews. And the benefit of these case reviews is to provide a confidential space to talk through CRP events among a panel of peers who will provide thoughtful and actionable feedback, support you in strengthening your CRP, and you'd be able to compare your approach to other organizations. But most importantly, our CRP services can support you in ensuring that your CRP is consistently applied and effective to meet Domain 4 of the Patient Safety Structural Measure. Our CRP certification program is endorsed by the Washington Medical Commission, and both services can be a great tool to supporting you in attesting yes to the CRP domain that we will be diving into shortly. And highlighted here are the two CRP services we offer at the Foundation, which is CRP certification and CRP screening. Both of these services are independent from one another, meaning that you don't have to participate in both in order to gain access to this space where you can safely discuss adverse events in CRP. However, each service does bring its own unique benefits that can support you wherever you are in the CRP implementation process. So starting off, the core foundation of our CRP work is our CRP review panel. The panel consists of peers in risk management, patient safety, doctors, attorneys, just a wide variety of healthcare stakeholders who have lived and practiced CRP. They bring a diverse perspective to case reviews and are equipped to support organizations in any aspect of the CRP process or addressing any questions, challenges, or barriers that come up. The first service is our CRP certification pathway. In this process, organizations who have fully completed a CRP event can submit the case to be reviewed by the panel. The panel will provide detailed and constructive feedback on what was done well and if or where there is room for improvement. Ultimately, having an event certified by the panel means that the organization has consistently applied all aspects of the core elements of CRP in their response to the adverse event. It means that patient safety improvements have been identified and met, and that post-event learning has occurred. And what's key about this process is that it's a thorough examination of your use of CRP, which can help confirm that your CRP is meeting the CRP requirements outlined in the patient safety structural measure. Also, as I mentioned previously, our CRP certification process is endorsed by the Washington Medical Commission. So for Washington hospitals, if you have a CRP event that is certified by our review panel, there is the option of submitting proof of CRP certification to the commission if they are investigating the case. Providing proof of CRP certification shows that your organization has taken the necessary steps to improve patient safety and implement systematic changes that will prevent similar events from happening again. So, providing the Commission with this evidence of CRP certification can add a favorable view to their investigation. And the second CRP pathway of support we have is CRP screening. This is a real-time consultation service where organizations can receive early guidance and support from our CRP experts as you're navigating an event or considering how to respond. This can be especially helpful for those who are newer to CRP or handling complex cases where you want a second opinion before moving forward. The primary difference with CRP screening is that the CRP process does not have to be completed before coming to the panel for support. This support is meant for currently active CRPs to ensure that the CRP requirements of the accountability and transparency domain are on track to be met, and that there is a plan for all of the essential elements of CRP to be used in the event response. So, whether you're well along in your CRP journey and looking for feedback on a completed case, or just starting out with CRP and looking for real-time support, we're here to help you strengthen your CRP practice in a safe and supportive environment. So if you have any questions or if you're curious to learn more about CRP certification or screening, please don't hesitate to reach out. I am more than happy to continue this conversation with folks and talk more in depth about these services or answer any questions you have about CRP or the review panel. And my email can be found at the bottom of this slide. So with that, I'll be transitioning to today's main event. It is with great pleasure that I introduce our two wonderful speakers today, Dr. Tom Gallagher and Dana Kahn. So Dr. Gallagher is a general internist who is a professor in the Department of Medicine at the University of Washington, where he is Associate Chair for Patient Care Quality, Safety, and Value. Dr. Gallagher is also a professor in the Department of Bioethics and Humanities. His research addresses the interfaces between healthcare quality, communication, and transparency, and he's published over 120 articles and book chapters. He is also the executive director of the Collaborative for Accountability and Improvement, an organization dedicated to advancing the spread of communication and resolution programs. And we have Dana Kahn, who serves as the Vice President of Quality and Safety for the Northwest region of Common Spirit Health, focusing on quality, patient safety, risk management, and regulatory compliance across the system. Dana has been with Virginia Mason Medical Center since 2001, where she has led large-scale strategic programs in quality and safety, including the Virginia Mason Patient Safety Alert and Response System. Dana serves on the National Patient Safety Council for Common Spirit Health and is actively engaged in the IHI PACT Collaborative, focused on nationally promoting communication and resolution programs to address harm in healthcare. So with that, I'm going to stop sharing my screen and pass the presentation over to Dr. Gallagher.
Thank you so much, Felicidad. And let me get my slides up here. Yeah. Can you see those okay, Felicidad?
Looks great.
Well, it is such a pleasure to be here this afternoon with all of you. As you heard, I'm Tom Gallagher. I've been here at the University of Washington for almost 23 years, and for much of that time have been partnering with the Foundation for Healthcare Quality on programs to both advance patient safety, but also to support the development and implementation of highly reliable communication and resolution programs. And so I could not feel more appreciative of the foundation, its support, all the wonderful programs that it has. And I hope all of you were paying careful attention when Felicidad told you about the CRP services. that the foundation offers, and that you will all take advantage of those outstanding resources. It's been such an interesting evolution to watch how the CRP field has evolved since I first started doing this work. It's been so exciting to see the field blossom from thinking about, is it okay to tell a patient and family about an error and apologize, to thinking about, well, is it okay to tell a patient and family about an error and apologize, and in some circumstances, maybe make an offer of compensation, to the full blown communication and resolution program model that we have and is being implemented by so many organizations across the country. But the field struggles with inconsistent implementation. And that, in part, is why some of the regulators and accreditors and others have started to move into this space with requirements or other strategies to encourage more highly reliable implementation of communication and resolution programs. And so, what we're going to talk about today, together with my colleague Dana Kahn, I'll be starting off and sharing a little bit about, well, what is a CRP and why it matters. Talk with you about some of the exciting developments in the national CRP landscape, including the CMS patient safety structural measure that Felicidad has referenced. And then we'll pass things over to Dana so she can share some of her observations about what their CRP implementation journey has been like. We'll talk for a few minutes about what some of the national resources are, in addition to the ones offered by the foundation, to help you with CRP implementation, and then make sure we leave ample time for questions. We have 3 learning objectives today. We want to describe the core elements of a highly reliable communication and resolution program, or CRP, and the benefits of these programs. We want to discuss recent national developments related to the growth of CRP for preventing and responding to harm events in healthcare. And then talk about what are some of the reasons why healthcare organizations struggle with inconsistent implementation of their CRP, and list the tools and resources available to support highly reliable CRP implementation. So let's talk a little bit about what a communication and resolution program is and why it matters. And the term communication and resolution program, or CRP, think of it as a generic term, and there are many specific examples of what a communication and resolution program could look like. For example, AHRQ's Candor Toolkit is one example. Many organizations have created and named individual communication and resolution programs. CARE, HEART, HEAL, all of these are examples of the generic term of what a communication and resolution program is. And, I became interested in this area early in my clinical training, when, like all
Oh God, we're gonna
clinicians,
hear the
we
story.
witness things that have not gone well in healthcare. And I personally struggled to know how to respond. I watched colleagues struggle. Oftentimes, we didn't say anything to the patient and family. When we did try to say something, it seemed just to make things worse. It was hard to tell whether the organization was learning from the episode. It was hard to tell whether the organization was really making efforts to make things right. So, communication and resolution programs really are about trying to encourage healthcare organizations, when something has gone wrong, to be transparent and to focus on learning. But unfortunately, that doesn't always happen. And we're going to talk about some of the reasons why that's the case. One of the things that's important to be aware of is some of the terminology in this area. Early on in the work, the focus was really on medical errors. So medical errors defined as the failure of a planned action to be completed as intended, or the use of a wrong plan to achieve an aim. And specifically on that portion of medical errors that caused harm. Was it okay to tell the patient and family what happened? That emphasis has shifted to focus on the much broader construct of harm events in healthcare, also known as adverse events or AEs. And as you can see from this graphic, most harm events are not preventable. Similarly, most medical errors don't cause harm. But you might think to yourself, well, why is it that we're focusing on this broader area of harm events, not just that subset that were due to medical errors? And the reason is because even if you were a patient who was undergoing a surgical procedure, you signed a consent knowing that a surgical site infection could happen despite optimal care. When you're the one who experiences that surgical site infection, you still wonder to yourself, why did this happen? Could this have been avoided? And I see we have several folks from risk, claims, legal on the presentation. They can confirm that a fair proportion of lawsuits actually originate from harm events that were not preventable, but where the communication was poor and the patient and family think something went wrong when it actually didn't. So we should be communicating effectively about all harm events, whether or not they were preventable. But we struggle. We struggle to respond to harm events for several reasons. Excuse me, it's human nature to want to keep problems to ourselves. Think about a time when you've been involved personally in something that went wrong, either in your professional life, your personal life. We all know that instinct and inclination to want to keep it to ourselves, to think, do I really have to tell somebody? If I just keep my head down, maybe this will all blow over. We don't like difficult discussions or conversations. Even at organizations that are highly committed to this work, I would say if we grabbed a nurse, a physician, pharmacist, social worker off the floor and asked them, what messages do you get from your organization about how to respond to harm events? They would describe pretty mixed messages. Mixed messages like, of course, we want you to tell the patient and family what happened, but don't say that. Or it's okay to apologize, just don't admit fault. And if you're a nervous clinician, not sure of what to say, those mixed messages just exacerbate our tendency to want to keep difficult information to ourselves. You know, early on in this work, the underlying assumption was that the primary barrier was fear of litigation, and that if physicians and nurses and organizations were not as worried about lawsuits, this would all be so much easier. And I'm not suggesting that clinicians and organizations don't worry about lawsuits, but I don't think that's the primary driver here. It is profoundly embarrassing to be a clinician who's involved in a harm event. I consider myself to be a capable clinician. I consider our organization to deliver high quality care. And when something goes wrong and I need to talk with the patient and family about what happened, it is really embarrassing. I'm ashamed. I worry about punitive consequences. I certainly didn't receive any training in what to say or do. And a big problem has been that there, up until recently, even for organizations that aspire to be open and use this approach, there weren't the tools, the resources, and the different elements of the response, whether they live in patient relations, patient safety, risk management, claims, legal. haven't been hardwired to work together effectively. And that is a lot of what the resources and training available today try to help with, driving highly reliable responses through hardwiring. There are more challenges. We don't know what to say. We don't know what not to say. The stakes seem like they are very high. We don't want to inadvertently make things worse. At many places, the status quo has been one of sharing limited information with patients and families. Attorneys, insurers are used to a status quo where a proactive approach is not as common, and changing the status quo can be difficult. There are clearly some cases where there was an obvious harm event and it was clearly caused by an error or system failure, but those oftentimes are the exceptions. Much more commonly, there was a bad outcome. We think that bad outcome was a harm event, an adverse event. When we look carefully at the care, there were imperfections. There may have even been frank errors, but it can be very difficult to know, did those imperfections or errors cause the bad outcome? And around the sort of the circle of people trying to respond are multiple stakeholders, whether they're clinical leaders, leaders of risk, claims, insurers, attorneys, who have important interests in how this process unfolds. And that can make it difficult to know how to respond. And we've talked about the lack of tools, resources, and standard work and measures, which fortunately now are all available to help with this work. So, what is a communication and resolution program, and why should you care? Communication and resolution program is a principled, comprehensive, systematic, and compassionate program for preventing and responding to harm events. It's a part of the CMS patient safety structural measure because at their core, these are patient safety programs. Our colleagues in risk, in claims, in legal are integral parts of these programs. We rely heavily on their expertise. But the places that are making the fastest progress are the ones that see these first and foremost as patient safety programs that are a part of our clinical mission. They're clinical activities that have legal consequences. They're not legal activities that happen to take place in the clinical space. And when organizations focus too much on CRP as a claims management strategy, it leads to cherry picking. It leads to using this approach for some cases, but not others. And that undercuts the highly reliable approach. It undercuts the culture change, the commitment to a culture of accountability and transparency. That's the hallmark of a highly reliable CRP. Multiple elements are involved here. Early incident reporting is vital. Although I would say in the future, I think voluntary incident reporting is likely to be supplanted and certainly just supported by new techniques to detect harm events through constant surveillance of the electronic health record. And it's remarkable how many more significant harm events organizations can detect when they broaden their funnel beyond just voluntary incident reporting. Open communication with patients and families, really good event analysis and quality improvement. For a small subset of harm events, it's probably 8 to 10% or so. Harm events that were due to error or system failure. Communication and resolution programs call for a proactive offer of financial, non-financial resolution rather than waiting for the patient and family to file a claim. This is really important because at the most highly functioning communication and resolution programs, the vast majority of cases that are going through are not harm events due to error or system failure. Although those programs are ready to respond effectively to those cases that are due to error or system failure. Care for the caregiver. I can tell you when I've been involved in serious harm events, for the most part, I have just put my head down and thought to myself, you know what happens, and moved on to the next patient. Was not a particularly helpful approach for me. And I doubt any of you wanted to be the next patient that I rounded on. Care for the caregiver, and this is an area where we've really seen wonderful developments at most institutions, programs to support the caregivers who are involved in harm event. And this should be the most patient and family-centered part of healthcare, the CRP process and the response to harm. I would argue at the moment it's the least patient and family centered. It's not that we ignore the patient and family on purpose. It's just that we're so focused on the impact of this event on us as clinicians, on the organization, that the interests and needs of the patient and family recede a little bit to the background. And in programs that really work well, patients and families are involved extensively and throughout, not only the affected patient and family, but the PFAC generally plays a critical role in developing and supporting a CRP at the organization. And I will say a little bit more about this in a few minutes, but our patient advocate community nationally has played really a critical role in many of the new developments in this space. For example, the CMS patient safety structural measure would not have been possible without the activism and support of an amazing group of patient and family advocates. So patients and families can be involved in CRP at multiple different levels. There are all sorts of benefits of a highly reliable communication and resolution program, not only for patients and families, for clinicians. It's clear that you can implement a CRP and not see an increase in liability expenses, although when CRPs are functioning well, there will be individual cases that organizations will come forward and tell patients about and potentially make an offer of compensation where if they hadn't done that, patient and family would have had no idea what happened. So it doesn't mean that this is a silver bullet, that this is a magic solution to make all lawsuits go away. But a highly reliable CRP overall can achieve all of these other benefits, and we're not aware of a single organization that has had a sustained increase in liability expenses, and some have seen savings. Felicidad mentioned that in Washington State, there's the additional benefit of, for programs that go through the CRP certification approach, as she described, the Washington Medical Commission looks favorably on those certifications as they're considering disciplinary action because the CRP achieves many of the things that they would hope to achieve by discipline. Now, that does not provide any sort of a guarantee, but the Washington Medical Commission does look favorably on the use of CRP in response to a harm event. And not only are these patient safety programs, they have a strong foundation in ethics. And this was a paper my colleague and I had come out a little bit more than a year ago in the New England Journal about CRP as the modern ethical paradigm for responding to harm events. But the challenge is really one of inconsistent implementation. And this is such a big problem because it means that fewer patients, families, clinicians, and organizations benefit. So all of these new initiatives, tools, and resources are really geared towards ensuring the reliable implementation of communication and resolution programs. So just a few minutes about the national landscape, and then would love to hear from Dana about what their implementation experiences have been like. If you haven't seen this recent evidence synthesis that my colleague Lauga Sokol-Hesner led, that I helped support and participate in, this was recently published on the AHRQ website, and it was a deep evidence synthesis and confirmed the CRPs are effective and worth implementing, and confirm the importance of robust implementation. And so if you really want to do a deep dive into what the evidence base is, what it shows, what it doesn't show, what additional research is needed, I would refer you to this document. There have been multiple areas where CRP has been on the national stage recently. The PCAST report, the White House President's Council of Advisors on Science and Technology, the Centers for Medicare and Medicaid Services Patient Safety Structural Measure that we'll talk about in more detail, the National Action Alliance to Advance Patient Safety, as well as the Accreditation Council for Graduate Medical Education. And we'll talk briefly about all of these. So PCAST was an important report from the White House. It talked about an urgent need to transform patient safety. It recognized accountability and transparency, as well as patient and family engagement, as being fundamental. And CRPs was one of the few specific patient safety initiatives called out for implementation, and we were pleased that the collaborative itself got a citation in this report. The CMS Patient Safety Structural Measure is a big deal. It took effect starting October 1st, 2024. It is an attestation measure. Doesn't require you to do anything, but it does require you to attest whether your hospital has demonstrated a structure and culture that prioritizes patient safety. It has multiple domains. The domain, while CRP could fit into any of these, accountability and transparency was the domain where CRP landed. And so there are two statements here, and this is important because affirmative attestation to all statements within a domain is required for hospitals to receive a point for this domain. So both statements are important here. Statement 4, our hospital has a defined, evidence-based communication and resolution program reliably implemented after harm events that contains the following elements: event identification, open ongoing communication with patients and families, event investigation, prevention, learning, care for the caregiver, financial and non-financial reconciliation, patient and family engagement, and ongoing support. That's awesome. But then statement 5 may in fact be the most important part of this patient safety structural measure as it relates to CRP. Our hospital uses standard measures to track the performance of our communication and resolution program and reports these measures to the governing board at least quarterly. The National Action Alliance to Advance Patient Safety also talks about CRP in their recommendation 9, which I think is great. And then ACGME, which is the organization that accredits residency and fellowship programs, in their proposed institutional requirements, which were released over the summer, they said at each PCLE, primary clinical learning environment, there must be a program for responding to harm events that includes the residents, fellows, and faculty members. The program must include residents and fellows and faculty members in communicating and seeking resolution with patients and families and support provided to clinicians following a harm event, and calls for policies and procedures for the actions to be taken after the occurrence of a patient and safety event with or without harm and distinguishing the role of the clinical patient safety program from the role of risk management. That issue in and of itself, we could spend a day-long symposium on. Now, the ACGME proposed institutional requirements were just that. They were proposed. ACGME got an enormous amount of public comment that they are currently digesting. So we do not know what the final institutional requirements will look like. But I think all of these signals really are pointing in one direction, which is an increased regulatory requirement and encouragement of organizations not just to have a CRP, but to implement processes for reliable enactment of their CRP each and every time there's been a harm event. And I'd like to pass things over to my colleague Dana Kahn. Dana is the VP of Quality and Safety at the Northwest region of Common Spirit. Dana has been a collaborator in this work for many, many years, and would love to hear your thoughts about what the keys to a successful journey have been for you. Dana?
Great. Thank you, Tom. And thank you, everyone. It's really a pleasure to be here speaking with you today, and look forward to the dialogue in the last bit of time that we have. Next slide, Tom. So I've been doing a little reflection on the past 2 decades. I've been with Virginia Mason Medical Center for over 20 years, and have been thinking about our journey. And there's really 3 main keys to success that I would like to share with you today. And they're listed here, and I'll wrap them up at the end. But the first is really to share that success is rooted in a broader organizational philosophy. And as I reflected on our safety journey, it really started way back in the early 2000s. And we've, the concept of CRP wasn't really established at that time. The concepts were there at Virginia Mason Medical Center, and those were things like doing the right thing, being transparent with patients and families, especially when we experienced the preventable medical error with Mary McClinton. And I would say the other component of that was rooted in our lean journey through the Virginia Mason production system, which got into the elements of event review and our commitment to that. Secondly, CRP journey, it takes work to maintain. So, you create your standard work and your approach and your process, but you have to constantly make sure that you're updating it, measuring it, understanding if it's effective. And then finally, good process can get better. And I think that's something we also learned through some of our merger and integration activities with Common Spirit Health, as well as Franciscan. And so through that process, we really took the best of both, and we continue to evolve. Next slide. Just diving a little bit deeper into our philosophy, the roots of the Virginia Mason production system philosophy, I think, really support our CRP program. And they're listed here, and they come from the Toyota production system. But the one that I really want to highlight that supports CRP is that focus on the highest quality and safety. And that has been really a prominent role for us. Next slide. So what does this mean to focus on the highest quality and safety? And this really is engaging the hearts and minds of all of our team members on small efforts and large efforts throughout the organization. It really needs to permeate beyond the bedside and into your non-clinical spaces as well, for it to really move your culture. The components of focusing on the highest quality and safety really means that everyone is an inspector, and that comes from our learnings through the Toyota production system. And what you see here in the image is the frontline operator doing their inspections of their work in flow, and if they find a problem, they can pull that cord and ask for help before that issue that they see actually becomes a defect down the line that reaches the customer. This work is also about embedding root cause analysis and mistake proofing into everyone's work, and also using failure to improve. That is really about learning. Next slide. As we worked to evolve and improve our process at Virginia Mason, we created these guiding principles, and this went all the way up to our highest level of leadership. Actually led a rapid process improvement workshop along with Gary Kaplan, and the team that we worked with actually created these guiding principles for the organization to support our CRP process. And I'll just read them to you, and there's a couple I want to point out, but they read that we will strive to see through the eyes of our patients. And secondly, we will commit to investigating the situation when there's a perception of poor quality. I think those two are really important and emphasize the point that Tom made earlier about the shifts we're seeing in the CRP space, going beyond just those preventable events, because they're complex, they're messy, and we don't always know what happened. And I think to step back and have that open mind about, let's try to understand what we can learn from this case and try to see through the eyes of our patients and communicate with them all the way through through resolution. We added that we support the emotional needs of the patient, family, and caregiver after an event. We keep information open and flowing. We tell patients and families what we know to be true when we know it, and that we acknowledge humans are fallible even within reliable systems, and approach our response with just culture principles and respect for people. So I think it's really important that every organization create their own and make it their own, and this has been very helpful for us for many years. Next slide. Over the years, we have worked to improve our standard work, and at the highest level, this is sort of the basis of our standard work. We look at it as 3 parallel pathways below that work together and coordinate, but below which has their own sets of standard work. So event analysis and review, ongoing communications with patients and families, and care for our caregiver colleagues. And we really lean on our patient safety team to sort of cross-functionally coordinate this entire process and make sure it's moving. They may not run every component of the process, but they're making sure that it's happening. Next slide. This work takes work to maintain, and we've gone pretty deep in our standard work for each phase, and we've called these unanticipated clinical events red safety events. Again, doesn't mean that harm occurred, we don't know, but it really allows us to step back, and when we have a concern that rises to that level, we will follow our standard work all the way through the process, and then really rely on our expert team of patient safety specialists to make sure that we're hitting all the elements, and also having the discipline to continuously improve all of our standard work, even in the face of constant change, whether we're going through a merger and acquisition or restructuring our teams. And the next slide. Finally, I think getting better is really important in continuing to evolve your program. I think striving to the point of being a thought leader out there, such as in the PACT Collaborative. What you see on this slide are some things we've been thinking about. There is a playbook. Common Spirit Health uses the Candor model, and so there is that higher level standard work that we continue to adapt our processes to. There's the PACT Collaborative, which Virginia Mason Medical Center engaged in 2 years ago to continuously improve our process. We actually did some work with our residency program to engage them in the work as well. Key performance indicators, that's something we are more recently working on, and Common Spirit Health is also developing standardized metrics for us to constantly understand if we are following all of our processes and reliably meeting the CRP elements. And then finally, this is an area that I've been thinking a lot about, and we've been developing standard work on, but these are those large scale safety events. This toolkit comes from the VA, but what I mean by those are those harm events or potential harm events that can impact many patients. Examples of that might be a major recall that you might need to disclose to patients and manage their care in that process. Maybe a problem that's impacting the environment of care that may cause potential harm or infection risk to patients, or drug diversion events that might cause potential infection risk to patients. So all of those, they can be challenging to manage, but I think the more you put some standard protocols in place to help you step through those, bring in the right people, really can reduce the effort that it takes, because they're just very difficult situations. And I think I just have one last slide and I'll wrap it up. In summary, I think keys to success include connecting to your organizational philosophy and embedding this in your clinical mission, memorializing your standard work and tools and use them and keep them updated. That will help you maintain a reliable CRP program. And finally, reserve and value time to improve your program through things like internal improvement work or external opportunities such as the PACT Collaborative. And that ends my presentation. I'll hand it back to you, Tom.
Thank you so much, Dana. You can see what impressive work Virginia Mason has done and what a great resource Dana can be for anyone who would like to chat with her about what this work has looked like there. Just very quickly, you've heard several times about PACT, and I'll say just a few words about this. There are a variety of learning collaboratives available around the country, and I would encourage you not to try to do this work by yourself. There's a large community of organizations working on this together, and that's what PACT is all about. It's focused on helping organizations achieve highly reliable CRPs through an IHI Breakthrough Series collaborative structure. 6 learning sessions are presented virtually. There are action periods, there are coaching, community forums, support, a whole host of tools, resources presented in a 12-month standardized curriculum, and all the activities of PACT are voluntary. So organizations decide what tools and resources to implement and how to handle individual harm events. This is a partnership between the collaborative, between Ariadne Labs, which is a patient safety innovation center based at the Brigham and Women's Hospital and Harvard School of Public Health, and then the Institute for Healthcare Improvement, the mission being to inspire and guide healthcare organizations in the implementation of highly reliable processes for responding to patient harm through collaborative learning, robust tools and resources, innovation, and the spread of best practices. And we've had great uptake. We're in the 3rd round of the PACT Collaborative. Just about all the major hospitals in Washington and many large health systems nationally have participated, as well as smaller community hospitals and other care settings. Just a small sampling of all the tools and resources that are available through PACT, and I would especially focus on measurement. As you heard from Dana, measures are an important way to understand how is your CRP process working, what are the opportunities for improvement. The CRP patient safety structural measure calls for these. So if you're not using some metrics to guide your work, I think it's really something you should think about. All sorts of tools for communication, for supporting the CRP process. We point to some resources developed outside, for example, the Betsy Lehman Center in Massachusetts, but a whole progress. The first 2 waves of PACT Collaborative, 28 healthcare organizations with nearly 50 healthcare facilities from across the U.S. We have, I think, 18 healthcare organizations participating in round 3, and all have made good headway, although it's a little bit of a one-room schoolhouse where some organizations started with much more developed programs and others are a little bit earlier in their journey, but they're all committed to moving forward, which is great. And here's what Alan Kachalia, who's the Senior Vice President for Patient Safety and Quality at Johns Hopkins Medicine, had to say about PACT. The PACT Collaborative has proved essential to helping health systems build CRPs that work. The strength of the collaborative lies in showing organizations how to convert CRPs from a vision into practice. I'd encourage any organization seeking to implement a meaningful CRP to join this invaluable effort. So it's such an exciting time in the field of communication and resolution programs. Regulators now are beginning to enact requirements for different aspects of the CRP process. And that's a reflection of the fact that despite the enthusiasm and the degree to which organizations are working to implement, the implementation has been highly inconsistent. Through participating in a learning collaborative, by taking advantage of shared tools and resources, and by taking advantages of the CRP services that the foundation offers, you can help move your organization along the journey to really having a highly reliable communication and resolution program with all the benefits that brings to patients, to families, to healthcare workers, and to organizations themselves. So with that, I will stop sharing, and Felicidad, if there are any questions, would love to hear them.
Yeah, what a wonderful presentation. Thank you so much, Dr. Gallagher and Dana. So yeah, if anybody has any questions, please feel free to put them in the chat. We also have a Q&A function where I can read it out. Or if you click more at the top, there should be an option for you to raise your hand and we can give you a call out. But first, while we wait for some questions to come in, I do have a question myself. So this is for both of you. In your view, what are some of the most critical steps an organization can take to ensure that their CRP is both effective and compliant with the standards that are outlined by CMS in the Patient Safety Structural Measure?
Dana, do you want to start?
Sure. I think I outlined a bunch of them already. I would say going through each of those domains and specific questions and doing a gap analysis, crosswalking with your current process, and then identifying what those gaps are. I think oftentimes those gaps that you identify can really be embedded into your standard work and written out, like how are you going to address that specific item. Even the metrics, I think you can put together a data definition sheet that might outline, what's your numerator, denominator, exclusion criteria, those kinds of things. And I think from the regulatory perspective, having that documented is going to be really important.
I would also just echo something Dana said early on. We see the organizations making the fastest progress where there is really strong leadership commitment to CRP, where there's leadership commitment to CRP as a clinical activity, as an extension of the clinical mission, where it's seen as a patient safety activity, and where it really is patient and family centered. Seeing things through the eyes of patients and families is vital. Organizations that lack that leadership commitment, it's really hard for them to make the progress that they are hoping to. And I would also just add the most common thing we hear from organizations that are interested in this work is, well, we already do this. And it's true that most organizations have the different elements. They have a process for incident reporting. They have a policy for disclosure. They have an event review process. They might have some care for the caregiver, There have been instances where they've made a proactive offer of financial compensation when they thought a lawsuit was imminent. But when you actually try to figure out, are they using this process each and every time? High harm, medium harm, patient aware, patient not aware, lawsuit likely, lawsuit not likely, each and every time. That's when they start to say, oh, yeah, no, we don't we don't sort of have this process hardwired. And that's where the real, I think, learning begins.
Yeah, absolutely. So you touched on the importance of having good engagement with leadership. What tips do you have for organizations who are starting off with CRP and don't have that leadership buy-in yet?
I think it takes time, and I think you have to you can work on this internally by sharing specific stories and kind of sharing what the outcomes of some of those events are. I also think, and we've done this at Virginia Mason as well, bringing in external experts can be really helpful, whether that's through a grand rounds where you might get somebody, a speaker or a patient representative, or bringing someone like Tom or other colleagues through the PACT Collaborative to discuss the broad elements of a CRP. And you could even get a group to do like a gap analysis of your organization and walk through each of those components.
And I would add, Felicia, I think it's rare that leaders aren't committed to the basic principles. They want to be open. They want to treat injured patients and families with dignity, respect, compassion, transparency. They want to support clinicians after harm events. But where they struggle is going from commitment to the high level principles to understanding what's involved with the actual execution, and have failed to make the work on CRP. We had an article about making CRP mission critical. And the organizations that are making the fastest progress are the ones where the leaders recognize this as not nice to have, not important or very important, but actually mission critical, and have committed the resources to achieve that goal. But it's rare that you run into a clinical leader who thinks, oh, if something goes wrong, we should not be open and honest with patients and families about what happened. So the general commitment is often there. As Dana said, sometimes it's a high profile case at the organization that gets them to realize that the processes they thought were working actually weren't working. And there are many very high profile cases in the national media where organizations that have been doing this work for a long time were surprised that the processes that they thought were highly reliable, when push came to shove and when a really awful event happened, they didn't work as they should have expected. But I do think that sometimes the focus on these highest harm events is a little bit of a distraction. One of the reasons Dana and Virginia Mason have been so successful here is the focus on the daily work. The what happens day in, day out. As Jerry Hickson is fond of saying, are you washing your dang hands? Are you doing the timeouts? Are you doing the little things that rely on a commitment to transparency, safety, and accountability? And it's those little things that really make processes like this work. And when they're absent, they accumulate and cause a big harm problem. But when there's a big case, we focus on what went terribly wrong and forgot about all the small things that happened leading up to this.
I agree with all of that. I agree also strongly that leaders you'll get the buy-in conceptually. These just take so much energy to execute, which is again why standard work is so important, because if you have that, you've got a playbook, it really helps you step through and lower that energy that's going through. It also makes your process transparent so people know what to expect when they're going through it.
Great. Thank you so much. And with that, it looks like we're at time. So thank you all so much for attending today's event. And as I mentioned earlier, I will be following up with everybody with a recording and slides of the presentation. So thank you so much, and I hope you enjoy the rest of your day. Bye.
Bye, thank you.